As Cyprian said, I'm Javier Bracchiglione. I am currently doing my PhD degree, and it is about overlap of primary studies in overviews. So it's quite an interesting topic. It's very methodological. In fact, it has not been so studied in the last years, I would say. So this presentation will be about overviews in general, but will focus mostly on overlap of primary studies. First of all, my conflicts of interest. I'm a member of the Cochrane Collaboration and the Great Working Group. I'm currently a researcher at the Ibero-American Cochrane Center. I'm a lecturer at Universidad de Valparaíso in Chile, and I have no competing interests relevant regarding this presentation. Today, we're going to see these general topics. First, talk about a little about the evidence ecosystem, about why overviews actually exist, what are overviews, some differences between systematic review and overviews, and particular characteristic of overviews, what do we use overviews for, where do I start with making an overview, and I will give you some supporting material, some general supporting material. So first of all, let's talk about the evidence ecosystem, because it is interesting to try to understand what overviews are good for, right? What are they useful for? Here we have a proposal for evidence ecosystem made by the MAGIC collaboration, where they propose, let me put this, the red dot. Oh, I think it's important. Let me, here it is. Okay. So first of all, we produce evidence. Of course, you all know this. The primary evidence is synthesized in mainly systematic reviews. Then we create guidelines, health technology assessment. We disseminate these products to policymakers, clinicians, and patients. We ideally implement that evidence appropriately. We evaluate the process, improve practice, and then we produce new appropriate evidence. That's theoretically a good way or a healthy evidence ecosystem. More recently, Holger Schoenemann has proposed a new model of evidence ecosystem, where he and his co-authors propose that all the evidence from primary research is synthesized in systematic reviews. Then those reviews are used for health technology assessment, guidelines, or other products such as essential medicine list, evidence-informed policy, coverage decisions, or quality improvement. Some regulators directly uses primary evidence, but this, independently of any of these ways, we all take a framework or a way to make a decision. In great terminology, we try to state what is the problem, the benefits and harms, values and preferences of patient, the cost, the certainty of evidence, and other key aspects depending on the question or the solution we want to make. We can use models, we make conclusions, and afterwards, we make recommendation decisions or take different options for clinical practice, public health, or health systems. So this could be a healthy evidence ecosystem too, but there is a key question here. What about overviews? Overviews are not here, are not in this evidence ecosystem, and these look quite good, actually. If we take this ecosystem or the MAGIC ecosystem and it works as it should be, then what do we want overviews for? Before answering that, let's talk about why overviews were born in the first place. When we want to talk about why overviews were born, we have to look at this, systematic reviews. Systematic reviews, as you all know, have been increasing in the last years. So that's the first reason why overviews were born. There has been a sustained increase in the number of published reviews. How much? Actually, a lot. I took a look on this today, and this is from the Epistemonikos Foundation, and they have calculated, they have an updated report, I think, every week about how many systematic reviews relevant to health for health decisions are published each year. So we see that during the COVID pandemic, there was a big increase in the number of published systematic reviews, but this has been increasing year after year. And there are no signs, no clear signs that this will be descending in the future. So that's a first reason why overviews were born. If there are a lot of systematic reviews, we need a way to synthesize those systematic reviews. But another issue is that it is frequent that we find discordant results between the systematic reviews. So, for example, this is a great paper where a case study of discordant overlapping meta-analysis of vitamin D supplements and fracture. These authors analyzed a sample of 7 out of 24 meta-analyses of high quality assessed by Amstar, and they found that there were important differences in study selection, data extraction, and methods of analysis. 3 reviews among those 7 did not identify all relevant primary studies, and 2 reviews included apparently ineligible studies. And what this caused is that they showed diametrically opposed conclusions between different reviews. So it seems that it depends on what review you're reading, the conclusion you're getting. So that's kind of a problem, especially when you're in the making recommendation decisions or you're part of a guideline development group. Some algorithms, so some decision algorithms have been published to try to solve this issue about discordant systematic reviews. This is a famous one from Alejandro Haddad, and that it addresses first if the different systematic reviews are addressing the same question. If they are considering the same trials, if those trials are of the same quality, or if they are not considering the same trials, if they had the same selection criteria. But unfortunately, this is not reproducible between different users. This is a great paper from Carol Lani from your university. Currently, there is no guidance on how to operationalize this algorithm, and authors recommend carefully choosing the systematic review that most closely matches the question of interest, that is recent, comprehensive, and at low risk of bias. So this is the ideal scenario, but there is no way to actually make this in a practical sense. No current algorithm solves this problem. And also there's an increasing interest in exploring new questions and broader questions. So these are the 3 main reasons why overviews were born. So what are overviews? First of all, they are a type of evidence synthesis. Overviews use systematic and reproducible methods and search, select, and analyze systematic reviews, not primary studies. So the main difference between an overview and a systematic review is that a systematic review includes primary studies and an overview includes systematic reviews. So if we have different population studied by primary studies, for example, this could be 1 RCT, 2 RCTs, 3 RCT, etc. For example, these 4 trials could be included in one systematic review. These 2 trials could be included in another systematic review. And we can include the 2 systematic reviews in one overview. So in simple words, an overview is a systematic review of systematic review. That's a clear definition, it's a simple one, and it's a pretty accurate one. An overview is also a design of evidence synthesis that usually answers broad but very concrete questions. And there are some particular characteristics of overviews. So I think these 3 are the main special considerations when making or reading overviews. The first one, that I think it's the most important one because it's probably the most unique, is the assessment of primary study overlap. The second one is the assessment of risk of bias within an overview. And the third one is the assessment of certainty of evidence within an overview. But let's focus on the first one. So I told you this ideal scenario where you synthesize the trials in individual systematic reviews and you include those systematic reviews in one overview, but this is an ideal scenario and it's not quite a real one. The real scenario looks a lot more like this. So the 2 systematic reviews can include some primary studies or can include the same primary studies. Somewhere when you're doing the overview, you're seeing, for example, this trial twice because you're viewing this trial through this systematic review and through this systematic review. This is what we call overlap of primary studies. Is overlap a phenomenon exclusive of overviews? Well, I'm doing now a systematic review about the effects of some immunotherapy and targeted therapies on hepatocellular carcinoma. And this is one of the studies we included, the REACH2. And you can see here that this is one of the big studies. They included 292 patients, 187 to the ramucirumab group and 95 to the placebo group. And then updating the review, I found this other study, REACH2 China, where they include 104 patients, but oh surprise, of these 104, 44 were included in the global study, and just 60 were new for this extension study. So here is an overlap of patients. It's an overlap that I can see in a systematic review. In my systematic review, if I include these two studies, I will have an overlap of 44 patients. Is overlap a phenomenon exclusive of overviews? Actually, it isn't. It could happen in a systematic review also. Actually, there are some papers talking about this, like this one, the overlap meta-analysis that synthesized the findings of primary studies based on large data registries, and this is the case of metabolic and bariatric surgery. And the authors say that whenever you do a systematic review, especially of observational studies, where you can include studies that are analyzing large databases, it is possible that you make a double counting of patients and their outcome of interest. Suppose that you're analyzing some outcome in cancer patients, and you find one systematic review that assesses a databases from 2006 to 2010, and another study that assesses the same database between 2009 and 2015. You'll have the patients from 2009 and 2010 overlap because you're counting them twice. So although overlap is not a phenomenon exclusive of overviews, it is probably more frequent in this research design. So let's dip a little more into this. Let's suppose we have 3 RCTs. This will be very graphic, no numbers involved, so it will be kind of superficial in that sense, but I want to make the point of overlap. So let's suppose in RCT1, we're testing drug A versus drug B. Patients in green were alive at the end of study. Patients in red were dead at the end of study. So RCT1 shows that drug B is way better than drug A. RCT2 shows a very similar result. So drug B is still way better than drug A. And RCT3 shows that drug A is better than drug B. This could be a plausible scenario in real life. So we're doing an overview, and we find 4 systematic review, and these 4 systematic review include these 3 primary studies. But none of them includes all primary studies. So systematic review 1 includes RCT1 and 2, systematic review 2 includes RCT2 and 3, and systematic review 3 and 4 have identified only RCT3. And we are the authors of the overview. So what is the truth that the primary studies tell us? Is that 2 of the clinical trials show a beneficial effect of drug B, 1 shows a favorable effect of drug A, and if we do a meta-analysis, probably drug B will be better than drug A. But what are systematic reviews saying? Systematic review 1 is saying, okay, drug B is better because it's looking at these 2 trials. Systematic review 2 probably says that there is no difference. Systematic review 3 says that drug A is better. And systematic review 4 also says that drug A is better. So as overview authors, this is what we're seeing. We're seeing the conclusions or the analysis of the authors of the systematic review. So it's easy to conclude as overview authors that the evidence shows benefits with drug A. And that's a major bias. That's a major mistake that unfortunately can be quite frequent. So we have to always remember that an overview analyzes systematic reviews, and that some of these reviews may be looking at the same primary studies. And this is what we call overlap of primary studies. So what is overlap? What is the definition of overlap? Is the double or multiple counting of the same primary studies that is included in 2 or more systematic reviews within the same overview. For example, a clinical trial could be included in 5 reviews within 1 overview. Why it is important, the overlap? Because of 2 reasons. First one is because if we keep double counting or multiple counting the same set of patients, we may artificially be increasing the precision of the results. And the second reason, this is more debatable maybe, but I think it's quite a good reason, that it may be biasing the results in the direction of the most overrepresented study. So for example, if this clinical trial, the one that is in 5 reviews within the overview, if we are counting this 5 times, we are giving a much narrower confidence interval, and also we are kind of biasing the estimate towards the result of that particular trial. What can we do to address or describe the overlap of primary studies? First, we can, the worst option, unfortunately, one of the most frequent, is just not considering overlap and just ignoring it. But among the good options you can take is first make a decision rule in the eligibility step. So for example, you can take some criteria for choosing only 1 review in case of overlap. So you may say in your overview, okay, if I find 2 reviews that include at least one that have at least 1 shared primary study, I will just include the most recently published, for example. We can also take an action at the time of data extraction or risk of bias assessment. For example, if we have 2 overlapping reviews, we can include both, but extract data from only one. For example, the one with the best AMSTAR score or the best ROBIS assessment. We can assess overlap during data analysis, for example, displaying or calculating overlap, or we can discuss it as a limitation of our overview. We'll focus on data analysis in this presentation. So one easy way to describe overlap is through Venn and Euler diagrams. So it's quite easy to see, it's quite easy to assess. For example, if we see this Venn diagram, we see that the study by Ray and the study by Moras share no studies, but Ray compared with CTT 2012 shared 25% of the studies. So it's quite easy to read this. But it's quite easy to read because there are only 3 systematic reviews. What happens if we increase the number to 5? Then it's quite difficult to read this. So it's very difficult to see which review is overlapped with which one. We can also make a matrix of evidence. This is probably the most recommended method to visualize overlap. So for example, this is a matrix of evidence. Here in the columns, we have the primary studies. In the rows, we have the systematic reviews. And the green intersections represent a primary study included in a certain systematic review. So here we can easily see, for example, that the review by Avi Rofé is the one that includes the most primary studies. None of the reviews includes all the primary studies. So it's quite easy to see. But again, in that scenario, it was easy to see because there were few systematic reviews. What happened if we have a scenario like this? Which one is the most comprehensive systematic review is quite difficult to see. Which one provides no unique data is also quite difficult to see. So in this case, from a matrix of evidence, we can do a calculation called the corrected covered area that provides us a percentage of overlap. How can we do that? We take a matrix of evidence. Please beware, here in the columns are the systematic reviews, and in the rows are the primary studies. It's the other way around from the ones I showed you before. And we can do this simple formula. So we take C, that is the number of included systematic reviews, that is the number of columns. In this case, it's 4. R, that is the number of index publication, or the number of rows, in this case 12, and N, that is the number of total primary studies, including the double counting. So in this case, is the number of green cells. And if we do this simple formula, we can have a percentage of overlap. So for this matrix, overlap is 22%. Is that a little? Is that too much? Well, there's a broad guidance where you can interpret that less than 5% is a slight overlap, 5 to 10 is moderate, 10 to 15 is high, and above 15 is very high. The question is the CCA enough? What if there are two identical systematic reviews in a big matrix? Will the CCA reflect that? And this actually was the story of the beginning of my PhD thesis, because we were working on a very broad overview about patients' perspective on type 2 diabetes self-management. And we had this huge matrix, 54 reviews and more than 900 primary studies. So it was quite big, quite difficult to read, quite difficult to make. But I remember there was this one specific review that included a lot of unique primary studies. So since it had a lot of unique primary studies and the other 53 reviews did not have those primary studies, the CCA calculation was very low. It was kind of diluted, but artificially diluted. And I started to look very close at this matrix, this huge matrix, and I noticed that there were some specific reviews that were very similar among each other. But of course, those were 54 reviews, so it was quite difficult to detect. But since the matrix was so big, the CCA was slight, was I think less than 1%. So I started to think, why don't we take a pairwise approach? So what I thought was, starting from a matrix of evidence, like the one I showed you before, I can make the same matrix, but for each possible pair of systematic reviews. So for example, in this case, I took just systematic review 1 and systematic review 2, and I made a little matrix with just these two systematic reviews. So I see the CCA, it's a little different. Not so much, but a little. So I repeated this process by each possible pair of systematic reviews. Here we have 1 and 3. Here we have 1 and 4. And oh surprise, first surprise, these two reviews are completely different. But that is quite hard to see in this matrix. Systematic review 2 and 3 are quite similar. They share 50% of the studies. So this is a pretty interesting finding, that the CCA apparently is not enough to describe the whole matrix. And this is quite useful the bigger the matrix it is. So we propose to take this assessment, each matrix assessment, each CCA assessment, and provide a figure like this. This we call group, graphical representation of overlap for overviews. And we made this triangle where we have all possible pairs of systematic reviews. And here it is the CCA calculation for each one of those possible pairs. So here we see that a lot of reviews are not overlap at all the 0%, but some of them, for example, Abdullah with Chen, share 50% of their primary studies. So this was quite useful, first to interpret the data and to discuss the limitation of our findings. But isn't this obvious? Like, if there's a low overall CCA, it should be a low pairwise CCA. I mean, if I have an 50% overall CCA for the whole matrix, and if I do this pair by pair approach, it is kind of obvious that they will all be high, right? If the initial one is high, each pair should be high. Actually, it is not. This is a paper we published recently in Journal of Clinical Epidemiology, where we looked at several overviews. Each one of these is an overview. We calculated the overall CCA, that's for the whole matrix, and we also calculated the pairwise assessment. That's for each possible pair of systematic reviews. So what we saw is that, for example, Some overviews had a moderate CCA, for example, 6.6 or 9.5, which is not too much. But when we looked at the pairwise assessment, we saw an important proportion of specific pairs of systematic reviews that had a very high overlap. So for example, in this case, despite there is a moderate overall overlap, 50% of the possible pairs of systematic reviews were very highly overlapped. And on the other hand, an overview that had a very high overlap had also an important proportion of specific pairs of systematic reviews not overlap. So it is quite different to have an overall CCA and a pairwise CCA. But is it worth it? Why do I need to do this? Why is it good to do this? And it's because it can guide your analysis and your interpretation of findings. And having this approach can prevent can prevent a lot of mistakes during the analysis or interpretation of data. Something like this. This is an overview that this is probably an extreme case. It's an overview that undertook a meta-analysis of meta-analysis. So each one of these studies, these are not primary studies, these are systematic review findings. If you see these two studies, this has to ring a bell. So you have the same number of events, almost the same total patients in both studies, almost the same estimates of effect and confidence interval. There's something fishy here. And if you see the group assessment, you can find that these two systematic reviews have 100% overlap. So here, what the authors are doing is that they are meta-analyzing meta-analysis. So they're giving over-precise estimates because they're counting the data multiple times, the data from the same patients. So if you have an assessment like this, you can prevent doing mistakes like this. But what's the reality now when talking about overviews? Almost a third of authors don't even mention overlap within their methods or results or discussion. Almost a third use some kind of visual representation, for example, a diagram or a matrix. A third discuss overlap as a limitation, and only 13% try to quantify overlap, and half of them uses the CCA approach. So it's still quite it's still not widely used, or authors of overviews are not quite using or considering overlap within their methods and their research. This is a big take-home message. We should always be aware of the overlap when conducting or reading an overview. But let's wait a little. The overlap and pairwise assessment that I showed you before is from this paper, but here is a phrase from the discussion. So we say, in our review, Marin Puyalto and Webster, two overview authors, reported a CCA of 16 and 54%. But our assessment, our de novo calculation of CCA, was 6% and 38%. Were we wrong? Were they wrong? What happened here? Because having a CCA of 16 that is very high compared to 6.8 that's moderate seems quite a big difference. So someone must have done something wrong here, because CCA is a pretty straightforward formula. It's nothing complex, and it is difficult to miscalculate the CCA. But we have to think that the CCA is based on a matrix of evidence. And the question is, how are we creating that matrix? And that may be the reason why the calculations differ. So this is currently what we're working on. We're trying to test the assumption for creating matrices of evidence to estimate overlap of primary studies in overviews. So we want to explore the variation in the estimation of overlap using CCA matrices under different assumptions. What are we referring with this? And we think this is what authors should be reporting in the future. First, we have the two basic concepts. Matrix of evidence, that a matrix of evidence is basically a grid that includes the systematic reviews and the primary studies. It represents a simple way for visualizing overlap. And it is quite useful when there's a limited amount of evidence. And the corrected covered area is a measurement of the degree of overlap or percentage of overlap of primary studies across different systematic reviews, and is calculated using data from the matrix of evidence. So we need to have that clear. So these are the two basic concepts for understanding overlap. Also, we have described two approaches to calculate overlap. So we have an overall CCA calculation, and that is when we only provide one value of CCA for the whole matrix. And we may take a pairwise CCA calculation. That is when we provide multiple values of CCA, and each value represents the specific overlap among a specific pair of systematic reviews for that matrix. So two approaches for CCA calculation. We can calculate CCA as an overall or as a pairwise analysis. But we also have three assumptions for creating a matrix of evidence. We can create a matrix of evidence making a scope adjustment, a publication thread adjustment, or a structural missingness adjustment. What do we mean by this? The scope adjustment, we need to consider that some systematic reviews may have included primary studies not providing useful data for the overview. So, for example, if you're conducting an overview about, I don't know, anti-diabetic drugs for older adults, I mean for 65 years or older, and you find a systematic review that includes adults 20 years or older, some of those primary studies that may include people from 20 to 40 years old are not useful for your overview. So you need to decide, should I consider that study for the matrix, or should I not consider that study for my matrix? So scope adjustment is the consideration and inclusion in the matrix only of the systematic reviews and primary studies or references providing useful data for a given outcome within an overview. This may sound very basic. I mean, if I find a study that isn't useful for me, I should not include that. But let's remember that when you do an overview, you're including the systematic reviews. And that systematic review may have one or two specific primary studies that are not useful for you. But detecting those studies can be quite time-consuming. So it's not so easy to do this. Despite it sounds obvious, for a resource limitation, some authors may prefer to just include all the primary studies included in all overviews, independently if they provide or not useful data. Publication thread adjustment. We need to consider that data from a primary study ideally is provided in one and only one manuscript, but this is usually not the case. It is quite frequent that one, especially big study, may be published in several journals because of a subgroup analysis, a longer follow-up, etc. And what is called sometimes salami publication. So we need to consider, if I have this paper of the 1-year follow-up and the 5-year follow-up, for example, this randomized trial, should that be just one row in my matrix, or should it be 2 rows in my matrix? And that can actually alter the calculation of the CCA. So public thread adjustment is the consideration of each set of references regarding a single primary study as a unique row in a matrix of evidence instead of different rows. So when we say that when you adjust by publication thread, each row represents the data of the same set of patient study. And the structural missingness adjustment refers that some intersections for a matrix cannot acquire values other than blank for valid reasons. For example, this is the most straightforward example. If a primary study is published in 2020, it cannot be included in a systematic review published in 2017. So when you adjust by structural missingness, what you're doing is you're modifying the CCA formula, and you're considering the number of the intersections considered a structural missed are subtracted from the denominator. So, starting from these two basic concepts, we can calculate CCA as an overall or pairwise approach, and we can make several assumptions for creating a matrix of evidence. For example, I can adjust by scope, but not by publication trend or structural missingness, or I can adjust by the three factors, or none of them. I can do any combination. And finally, the overlap can be analyzed at two levels. I can make an overview level overlap assessment, and that is the consideration of all the evidence for creating a matrix and calculating CCA. So we take the overview as a whole as a unit of analysis, including all the outcomes in the overview. But another option is taking an outcome level overlap assessment. So in that case, we're considering the evidence providing data for each specific outcome for creating a matrix and calculating the CCA. So in this approach, we take every outcome as unit of analysis, and therefore we should provide multiple matrices, one matrix for each outcome of the overview. This is quite similar to what historically happened to risk of bias assessment. So 15 years ago, 20 years ago, I don't know, risk of bias assessment in systematic reviews was done at a study level. So we said that the study had a low or high risk of bias. Nowadays, for example, within the grade framework, we analyze the risk of bias at an outcome level. So that can be quite different. This is the same underlying concept. Starting from these two basic concepts, we can take three assumptions for creating a matrix. We can take two calculation approaches, and we can take two different units of analysis. When I told you that our calculation of CCA differed from the ones that the original authors of overviews provided, this is the reason why they were not the same. For example, we did not make any adjustment for creating the matrix. So we consider all the primary studies in all systematic reviews. Does this really influence the overlap assessment? Because this all sounds theoretically interesting, but does this really make a difference? We don't know yet, but here's a preliminary experience. This is an overview we published, I think, last year, about the effectiveness of non-pharmacological interventions to prevent adverse events in the intensive care unit. And what we did is we took advantage of this overview to test some part of this approach. And here we have the overlap assessment, 37 systematic reviews, 246 primary studies. The overall CCA, considering all systematic reviews and all primary studies included in the reviews, was 1%. Pretty low, actually. When you say 1%, you say, okay, this is pretty low. I should not worry about this. But we also did CCA at an outcome level. And when we saw each outcome, okay, CCA for the first outcome, 52%. This is a huge CCA, and 38%. So this is very, very, very high. And when we did the pairwise approach, we found, for example, scenarios like this, where we found that some pairs of systematic reviews were absolutely different, and some of them were actually the same systematic reviews or included the same primary studies. So the calculation actually differs a lot depending on this assumption and on the unit of analysis you're taking. But to provide more definite conclusions, we'll have to wait for us to finish this research. Where are we now in terms of overview? As I said before, many overview authors do not even consider overlap. Among those that consider overlap, few create a matrix of evidence or try to calculate the CCA, despite being among the most recommended methods to describe overlap. And it is not studied why authors are not doing this. It is probably, I think, this is my perception, because it is quite time-consuming. But what I propose is that from now on, authors should at least clearly describe overlap. I recommend using a matrix of evidence. Try to quantify overlap. I would recommend through the CCA calculation and report what assumptions are they making when assessing overlap, because it could be quite different depending on the assumptions. Are there any pending tasks in this? Well, first of all, I have talked about the CCA interpretation, and I said 5, 10, and 15% were the thresholds to interpret this. But what does this mean, actually? If a CCA is very high, is that my results are wrong, are misleading? If it's slight, is it all okay and I should not worry about? And why 5, 10, and 15? Why no 10, 20, 30, or 25, 50, 75? Actually, this was the original proposal by David Piper, but there is no epidemiological rationale for this. This was just an initial proposal that overview authors tend to replicate, but there's no major reason for these thresholds. But I think that first we need to make an agreement or a consensus about how to describe overlap, all the aspects that I talked about before. Then, once we can make a consensus about how to describe the overlap, how to report what are we doing with overlap, a pending task will be to assess the impact of overlap on the findings. And then we could set a threshold, a more accurate threshold, or make a rationale about why we're putting the thresholds. Maybe we don't even need thresholds. I don't know. That's a pending task. Another pending task is, let's think about these two scenarios. So I will put this matrix of evidence that you can clearly see that systematic review 1 and 2 share one primary study, that is primary study number 5. That's the only overlap study. And if I put you this other matrix of evidence, you can see that it's the same scenario. They share the same primary study. So in both cases, the CCA is 10%. But these are quite different scenarios. So in the first scenario, both systematic review provide apparently useful data. But in the second scenario, it's just systematic review 1 that provides all the data. So something is missing here. We're not quite describing the phenomenon so correctly. So we may also need to estimate the uniqueness of the data provided from each systematic review. And probably in the future, we will need to make this complementary assessment to overlap. Try to make a uniqueness index or something like that to try to capture this phenomenon. So I think I'm about to finish the time here of the presentation. I will do this very quickly. Risk of bias in an overview is another special consideration, but I will just say 2 words about this. When you're authoring an overview, you make the risk of bias of the review, but you also need to consider the risk of bias of the primary study. So risk of bias is at 2 levels. So a systematic review includes an analysis primary studies, including risk of bias. An overview includes an analysis systematic reviews, including risk of bias. But since reviews include primary studies, an overview could also analyze the risk of bias of primary studies. The same principle applies to data extraction. Options, the worst option is just don't make a risk of bias assessment. And then you have plenty of options, just assessing systematic reviews, and reporting how systematic reviews assess risk of bias of the primary studies, assess systematic reviews, and try to determine the risk of bias of each primary study with the information provided to you, or just make a de novo analysis of all systematic reviews and primary studies. So this is an example from a published overview of our team. Here is the AMSTAR 2 assessment of all the included systematic reviews. And here is the primary study assessment of risk of bias according to the systematic review authors. All the things that you see with a question mark are represents unclear assessment by overview authors due to simultaneous low and high risk assessment made by 2 or more systematic review authors. This was presented in Cochrane Colloquium last year, so if you want to see the details of the presentation, here it is. So an overview includes reviews, which in turn include primary studies, and therefore the assessment can be done at these 2 levels. And the same applies to the certainty of evidence, currently there is no guideline for assessing certainty of evidence in overviews. So you can just not report the certainty of evidence, report it as it was reported by the overview authors, or try to attempt to make a de novo certainty of evidence assessment as if you were doing a systematic review. That's a little more difficult and not quite clear how to do that. Will there be a guideline for the assessment of certainty of evidence from overviews? I really don't know, because if I see the evidence ecosystem again, overviews are not here, not within the evidence ecosystem. So I don't know if that will be a logical development in the future. So what do we use overviews for? According to the Cochrane Handbook, it's for assessing different interventions for the same condition, different approaches to applying the same intervention for the same condition or population, the same intervention for different conditions or populations, for assessing adverse events of an intervention in one or more conditions or populations, or for assessing same intervention, same condition or population, but with different outcomes or time points. Always in the case that there are two or more systematic reviews that have addressed this question. In my opinion, an overview can be used to explore how the same or different intervention behaves in the same or different population, quite similar to what Cochrane says, to explore very broad questions, which will take an immense effort if covered by a systematic review. For example, if you want to analyze the effects, I don't know, of analgesics in low back pain, like an overall, it's quite a big effort to do one systematic review of all. So an overview could be a good approach to address that. To facilitate knowledge translation to non-experts, maybe some people that don't have the required methodological background to read a systematic review or a network meta-analysis, an overview can be a more friendly way of gaining that knowledge. To support decision-making, but by providing kind of a big picture and not a specific estimate of effect and confidence interval. And for conducting meta-epidemiological research, I don't know about this, because in meta-epidemiological research, if you do a research where you include systematic reviews, for example, to analyze their quality, and that's your aim, it can be considered an overview, but other people could say it's just another type of research. It's just a meta-epidemiological research. So I don't know if that fits quite good in the definition of overview. So where do I start when I want to make an overview? First, defining the research problem, obviously, and the research question. And then you should decide which methodological design might be most appropriate. Generally, an overview can be a lot more friendly and easy to read than a systematic review, because they tend to be more descriptive, less statistically complex, more general. But that's for the reader. For the author, it requires quite an extensive methodological knowledge, because you need to know how to conduct systematic searches and select systematic reviews, and you need to be able to assess risk of bias of reviews of primary studies. You need to know about overlap and how to properly address it, and you need to have experience in how to analyze and present results from both primary studies and meta-analysis. Always, overviews should have a team with at least one methodologist with experience in overviews, or at least in systematic reviews. And also be clear about the purpose of your overview. Is the overview really necessary, or you're just doing a new systematic review and a broader systematic review? Obviously, make sure you're not making waste research, that there's no similar overview being conducted somewhere else. Make that register your protocol prospectively. Use a proper reporting guideline. Prior is the preferred reporting items for overviews of reviews. Is like the Prisma of overviews. And good luck with the overview. So some supporting information, just to be finishing. There are these are in order from the list, from the most basic to the most complex one. First of all, Cochrane has these initiatives, starting for Students for Best Evidence, or Estudiantes por la Mejor Evidencia, that is the Spanish version of this. Here, some students, from med school students to doctorate students, post some blogs about the different topics. I have posted a blog in the Spanish version of student for best evidence about overviews. In University of Valparaíso in Chile, we have this methodological series published in one journal. It's called MedWave. It's a Chilean journal where we kind of addresses the topic for a broad audience, for non-experts. This is one of the papers we recently published about overviews. Of course, the Cochrane Handbook has the new version of the Cochrane Handbook has a chapter for overview of reviews where you can find the methodological guidance to do them. Prior guideline should be the preferred guideline to report overview of reviews. So some recent developments, such as the overlap of primary studies, is included in prior. These two papers, actually by Carol Lani, are great. They are two systematic mapping of all the methods available for overviews, all the recommended, the not recommended, everything that has been done in an overview is included in these two papers. They are quite great. And if you want to get a little more involved in the overlap issue, here are four important papers. First one is the paper by David Piper, where he describes the CCA formula for the first time. And Carol Lani explored the concept of overlap as a definition. Here is this paper by Bo Giokas, I think it's called, and where he talks about how to visually assess overlap. And here is our paper about the group tool. This is the pairwise approach to calculating overlap. So some key messages to be finishing. Overviews are systematic reviews of systematic reviews. They were born due to the increasing number of reviews. There are sometimes discordant results, and they need to explore broader questions. The main difference with a systematic review and other types of synthesis is their unit of analysis, because overviews analyze systematic reviews. An overview tends to answer broad but very concrete questions. Overviews have some methodological particularities, including the overlap of primary studies, the assessment of risk of bias at two levels, and the assessment of certainty of evidence. Overviews may be described or analyzed in several ways, but matrices, overlap, but matrices and CCA are among the most recommended methods. There are still many pending tasks in the development of methods to assess overlap within overviews. And reading an overview can be easy, but doing an overview requires a lot of methodological expertise. So thank you so much for being here, for hearing me, for your attention. Here is my X or Twitter account. If you want to contact me, just write me there.
Thank you, Javier. Thank you for a wonderful presentation. Carol had warned us that there is a whole universe in the overviews of systematic reviews, and you gave us a glimpse into this. I guess we can take a couple of minutes for questions if there are any. There is one question in the chat that our colleague Guillaume Grenet has asked, and is asking how it can be acceptable to meta-analyze the estimates from previous systematic reviews rather than just using the previous systematic reviews to extract the data from the original primary studies and basically meta-analyze again the primary studies. Of course, that would avoid the issue of overlap, but maybe you can address this.
Yeah, how that can be acceptable, I don't know, because it shouldn't be acceptable. I have read one paper, I think it was from 2012, that some statisticians made a special method for meta-analyzing meta-analysis under the assumption there was no overlap. That was the only assumption they made. But that scenario is quite infrequent, because if you include several systematic reviews for a certain research question, you expect that some primary studies should be overlapped. Actually, it should happen. It is expectable to happen. So you shouldn't do that to meta-analysis. And actually, I would say that if you want to make or report meta-analysis within an overview, you have basically two options. One, if just to take the data from the primary studies, you can go directly to the primary studies, or take the data as reported in the systematic review and make a meta-analysis taking as unit of analysis the primary studies. Or you can just simply report the meta-analysis made by the systematic review authors. But I cannot think of a circumstance where I will recommend a meta-analysis of meta-analysis. With current methods, it shouldn't be done.
Wonderful. Well, thank you very much. A lot to think about.